Okay. Are you ready? Can I go ahead?
Yep, we're ready to go.
Ready to go. Okay. Good morning, everyone. I'm happy to be part of this workshop, and I'm glad that I can share some experience with you from far away, since I'm right now in the middle of the night in Sweden. But I like Australia, and I like to share my experience with you. I will give you a brief introduction to myself, and also to the environment where I work and practice. And I will then tell you that I'm a professor at the Karolinska Institute. I'm an MD, PhD, and I sustained a spinal cord injury myself 32 years ago in a diving accident. So talking about disabilities, disabilities do occur in every part of the world. Let me see now. It's a little bit lagging, yeah. But this picture that shows people with amputees and other types of severe disabilities have been present in all cultures, in all parts of the world for centuries. But when it comes to spinal cord injuries, they have only survived after 1948. Almost every spinal cord injured person died before that date. And they didn't die from the spinal cord injury, but they died from secondary complications. And one of the most severe complications those days were septicemia, that caused by primarily infections from the bladder that went up into the kidneys and then into the bloodstream, and that was the cause of death. Anyway, dealing with spinal cord injuries, you are probably well acquainted with the fact that you divide spinal cord injuries into tetraplegics and paraplegics depending on where the injury is. In other words, if you have a spinal cord injury in your neck, you become a tetraplegic. If you have a spinal cord injury in your back, or your thoracic or your lumbar part of the body, you become a paraplegic. So the good news is that we have more survivors today than we have had ever before, due to the fact that emergency care is better with airbags and everything, and also emergency care has higher status, so that's the reason why they get more money allocated to that type of business. But the interesting thing is then that the bad news is that we have to take the responsibility also to get these people back into society, and that has been a sometimes completely different ball game. This picture it's on the screen now is taken the 15th of June in 1984. It's my wedding picture. It's taken about 2 weeks after my spinal cord injury. I had to have my bachelor party in the hospital. I was in a striker bed. I was fused between my 5th and my 7th vertebra. And the most interesting thing with this wedding picture was actually that the dean of the university hospital tried to stop this wedding because they didn't think that I was going to be more than a vegetable the rest of my life. And the more we think of that and the more we consider that, it's pretty disgusting that people like the CEO of the hospital and the dean try to exercise their authority. They called in my parents, even though I was 30 years of age. Anyway, we got married, and I had to spend a summer in an ordinary hospital bed, and that looks pretty much the same at North Shore or anywhere in the world. It's dull and ugly, and it's a pretty stressful time when you have to realize that the rest of your life you're confined to a wheelchair. Anyway, after 3 months in the hospital, I tried to get back working, and it was difficult to get back into the operating room and into the emergency, but I worked in the ICU, and it became important with all the stigma that scrub clothes and white gowns, stethoscope and everything, because I, as everyone else, wanted to be part of society. I didn't want to be a crippled, a lame, or somebody that was asking for pityness. I wanted to be a part of the rest of the crowd. I wanted to learn more about spinal cord injury, so I looked around to see where I could find one of the largest hospitals and best care at that time, and I ended up in Perth in WA, where I spent 1 year together with Sir George Bedbrook in Shenton Park at that time. And at Royal Perth, there was also a very well-known neuropathology with Professor Byron Kakulas, who saved all specimens, all spinal columns and all spinal cords from every spinal cord injury victim that died, no matter if they died at the injury site or if they died 30 years down the line. And we learned a lot about pathology, extension, rotation, and so on. And when I came back, I wanted to start a spinal cord injury unit in Stockholm in Sweden, and the local municipal health authorities thought that the spinal cord injury care was good enough. So we had to start really from square one. And this is on the ice during the inauguration of the big sport arena together with some famous sport legends. And we actually started a fundraising with piggy banks, and then we got a large number of good sponsors with us in order to embark onto something that was private, non-profit, which I still believe sometimes is the best way to conduct medical care without any big financial stakeholders, but rather having a foundation running it. And if you make a surplus, it goes into the foundation. So after raising a considerable amount of money, we then managed to get a floor in a hospital that was pretty ugly, and we wanted to make an interior revolution. So we actually redesigned and did an awful lot of refurbishment in that, on that floor. And we made ellipse-shaped corridors, and we painted them blue, and we changed the lighting, and we turned it into something that almost looked like an art studio. We had an old car in there for practicing transfers back and forth, and we made it very futuristic with the tables hanging from the ceiling, which is practical if all your customers and patients are in wheelchairs. So this was the reception area. This was my room back in the early 90s. And we then managed to get a lot of attention, and we made a kitchen in this unit that became famous because everyone wanted to hang out in the kitchen. In the beginning, a lot of people were skeptical, but after a while they realized that kitchen is always a good place to relax in, and as you are aware of, all good parties always end up in the kitchen. So I wanted my kitchen to smell from garlic, red wine, that's really what it turned out to be. It was used for team meetings and a lot of other meetings as well. So Spinalis was created as a unit at the hospital, as a research institution, and then we had the foundation. And today we cater for over 1,200 spinal cord injury patients in the greater Stockholm area, and we have about 50 new cases a year, and we are of course trying to strive for better clinical research. This old picture that has cure at the top pretty much reflects reality, because basic science usually get much more attention, much more resources, much more money, whereas clinical research is always sort of second on the ball, and even though the patients a lot of times would like to get more resources to clinical research. But every now and then things happen, and this guy, Ian Burkhardt, that you might have heard of in the news the last week, because this chap who has C4, C5 injury actually was operated on and has a chip in his brain, so he can and the cable from his head goes into a computer that assembles those signals, and that goes out to his right lower arm, and with this technique he can then control his arm a little bit and actually also pour water into a glass. And I met Ian a couple of years ago, and when you embark onto things like this, you need an awful lot of endurance because it takes time to acquire this. And I tell you the truth, even though I've been very skeptical to a lot of these things like the biofeedback, the biomechanics, and the skeletons, I believe that this might be an opening, but still we have long time to go. If we ask our patients what they would like us to concentrate on, it's quite clear. It's pain, sex, infertility, incontinence, and spasticity. And we have tried to actually focus on that when it comes to our research. And in order to sort of maintain quality, you have to conduct evidence-based medicine. You have to rely on good science in order to conduct proper treatment. And that's the reason why you actually have to go into research, and we have produced 10 PhD theses up until now, and we have always quite a large number, considering our small size, of PhD students that go through the scrutinizing, that become part of our crew. Anyway, looking into the problems, pain is the biggest problem for spinal cord injury patients everywhere. 40% of spinal cord injury patients are complaining about deafferent neuropathic pain that usually it's extremely difficult to treat with any type of medication, and it is very difficult. But another problem is, of course, incontinence. If you cannot control your bladder, if you cannot void normally, usually that is it's a huge dilemma for these newly injured patients that both psychologically and anatomically feel frustrated about these things, and it becomes an obstacle in the beginning just to learn how to handle this. And accidents happen every now and then, and every time an accident happens, you're always concerned about the fact that you couldn't avoid that. It happened. You try to do everything you can, and if you don't shape up, you will always risk to come into a disaster. So high quality of life impact of UTIs, which is quite common among all us spinal cord injured victims. I would say that 30% of all my patients, they have recurrent UTIs almost all the time. And I'm frustrated, and also I'm more than frustrated. I'm furious about the fact that research and resources has not been allocated to learn more about how to avoid UTIs. The ordinary thing is that 23% of them feel ill for 4 days, and you miss school, and they refrain from social activities, become more isolated, and the quality of life score is then dropping. And when you, as a spinal cord injured person, are addressing this matter to your doctor, the answer is always the same. And I know a large number of my patients feel upset about the way the medical profession neglect the fact that this is actually something that is bothering 30–40% of this entire constituency over time, all the time. And the routine is that if you run fever, you take a culture, and if the culture is positive, then you should treat it with antibiotics. And the interesting thing is that the more we treat our urinary tract infections with antibiotics, we are of course risking to get resistant germs that we cannot treat any longer. And if we don't watch ourselves, it might be that 10, 20 years from now that people with spinal cord injury suffering UTIs will actually die from pretty simple infections because we don't have any drugs, we don't have any antibiotics left that can treat them because the bacteria have become resistant and there is no way that we can treat them. So what should we do in order to be aware of that? What can we do in order to have a good management routine to minimize the amount of UTIs? Well, the golden standard is single-use catheters, both in hospital and in the community. If you're in a hospital, you could pretty much perform a sterile, intermittent catheterization, but if you are at home, you can do it clean. And you should do it 4 to 6 times a day. You should keep a bladder volume around 4 or 5 mil, 100 mils, adequate fluid intake, and of course you should have a hydrophilic catheter and not make around with gel or lubricant and all that. Those were the days when we were back in Perth in the mid-80s, and there were like Tupperware parties at the hospital where people actually had plastic bags and they putting gel into the plastic bag and then a catheter, which of course then created and generated more UTIs. And it's important also for caregivers to be very hands-on when it comes to teaching the technique to make sure that the patients are following the recommendations and that they have compliance, and we're dealing with motivation, a good education and active follow-up. It's interesting that there are still countries, a lot of civilized modern countries with high technology that haven't really been able to understand the necessity of this. It's like other parts of healthcare are much more sensitive vis-a-vis new innovations, but in certain areas it's much more difficult. And if you want to be really safe, you should use a catheter that has a special device on it, so that you can, like an introducer, which means that you can actually keep your fingers on that white device on this picture and introduce the catheter into your urethra, empty your bladder without ever touching the catheter, the touchless method. And this can be done anywhere, in a car, in a boat, in an airplane. You can hide behind a curtain in a restaurant or whatever. So the bottom line is to do whatever you can to persuade the local municipal health authorities or the local government to make sure that they take the responsibility, because it's our health, it's your health, it's my health, to be sure not to suffer UTIs if you don't have to. So anyway, other problem is then your bowel program to evacuate your intestines and to be able to actually have your stomach work properly. And I would say that the most sad thing is when you see healthcare givers giving too much laxatives, and also the wrong types of laxatives, not the bulk ones, but the ones that are actually affecting the neurons outside the intestines, which is bad. There's an elephant in the room, and what is that? It's about sexuality, and I learned that you will have a lecture later on today about sex and spinal cord injury, and it's really an elephant in the room because it's something that everyone have suffered from spinal cord injuries keeping their minds on, but there has been very little good education conveyed and communicated to the constituency, the spinal cord injury constituency. And 30 years ago, it was quite common among urologists to work for implants, which never really worked. The urologists were more interested in the patients, which is typical for surgeons, that they think that they can solve it by using the knife, but it's not always the case. So it was not until 1996 when sildenafil or Viagra was introduced. Actually, this drug came on the market in a clinical trial in Buckinghamshire in the UK, and Pfizer introduced it, thought it was going to be good for angina pectoris, but it never worked for angina pectoris. But when the clinical trial was over, the men that was part of that clinical trial, they didn't want to hand the medicine back to the company because it worked not on the heart but on another organ, namely the penis. And I was the principal investigator on the largest Viagra study in the world with spinal cord injury patients when I followed 166 couples during 18 months. And it proved that the possibility to actually have intercourse increased with 80% in that group. So the question is then, when it boils down to sex and spinal cord injury, can you have sex if you're spinal cord injury? And the answer is yes. Next question is, can you get an orgasm if you have a spinal cord injury? Well, if you're a woman, it's easier to get an orgasm than if you're a man. And now I'm talking about the true orgasm, which is the release of an octapeptide from your hypophysis in your brain. So the next question after that is, if you cannot get an orgasm, is it still worthwhile striving for to have sex? And the answer to that question is yes. And why is that? Because there is a unique intimacy in a sexual situation that cannot be replaced with anything else. And it needs a little bit of hands-on care in the beginning before you become acquainted with your new situation. But the history proves again that if you keep your sex life fairly active after your spinal cord injury, it's easier to maintain it over time. Sometimes sex is also resulting in sperms, and sperms can hit an egg, and when a sperm hits an egg, you might get a fertilized embryo. And in 1984, when I had my injury, I was taught, or I was informed about the fact that I could not get biological children of my own. But with the use of a vibrator, and this is the picture of the Danish FurtiCare vibrator, which is the best vibrator on the market. You can change the amplitude and the frequency, and with that you can get sperms from about 60–70% of all men with an injury above T9. And if that doesn't work, you have to use an electroaculation. And my colleague Vernon Hilly from Brisbane has been very active in this field for 30 years, both with electroaculation and with a vibrator. And this is me doing a procedure, and I have to have the patient during general anesthesia because it hurts if you have sensation, if you have a lower spinal cord injury in your lower part of your thoracic or your lumbar part of your spine. And then when you actually use a probe to stimulate the hypogastric nerve, you can then get a good amount of semen with this technique. And today you can use it for ICSI, intracytoplasmal sperm injection, where you actually deposit one sperm into the egg. And this is something that is practicing now more and more all over the world. And this is a picture of me and my wife and my son Emil, who was born in 1992 and was one of the first children born with a spinal cord injury father, where the injury was complete. Well, my friends, why do I show this picture? Because this is probably one of our biggest problems. If our unit serves and caters for over 1,200 patients, half of them work and half of them do not work. And the ones that do not work, they turn night into day and day into night, and they becoming more social, or they don't really integrate into society, and they start also to actually neglect part of their body. And when a person like this sometimes come to my outpatient clinic, they say, I have a little wound on my butt, and then they come in and have a pressure wound like this. And this is something which is so bad. And this is, if it's not UTIs, it's pressure ulcers that causes so much problems and so much infections and so much pain in all various ways for these patients, because it takes months to cure sores like this with plastic surgery. So life is not only the body, life is also the environment, and sometimes when it comes to making an environment accessible, some authorities believe that everything has to be really streamlined and follow all the regulations. What's missing a lot of times is fantasy. And you see that when you work in the developing countries, like in Africa, where we've been working in Zambia, in Namibia and Botswana. You have to use your imagination and fantasy in order to make sure that you can access your bathroom, you can access your kitchen, etc. So learn how to ride your not your bicycle, but learn how to ride your wheelchair, to climb curbs, to do escalators, and sometimes even if you practice very hard, there are situations that will always be awkward and difficult. It's like wet sand, or if you're aboard naval ship, a naval ship cannot be wheelchair accessible, and then you have to realize that that's the truth. So then you have to rely on other people, and you have to rely on other people still keeping your integrity. And I think that's an equation that we have to take, all of us, not to give up your self-esteem or your integrity, but rather ask for help when it's needed. This is a 2.4 meter, which is actually a sort of replica of the big 12 meters. And during the Paralympics in Sydney in September of 2000, I sailed this type of boat on Sydney Harbour outside the Sydney Opera, and that was a very exciting moment in my life to sail in the Sydney Harbour during the Paralympics with a 2.4. And the best thing with this class is that it's 100% integrated. You cannot tell from this picture whether this person is an amputee, a paraplegic, a tetraplegic, a CP, or a hemiplegic, or if it's just a normal walking person. And during a world championship today, with over 100 helmsmen, usually about 25% are people with various types of disabilities, and that is the most the most astonishing integration that we can see. When you have this integration, and it's happening in a sort of a natural way. And this is not a picture of a collective joint suicide with wheelchair confined persons. This is just a jetty during one of these sailing events. There are a lot of things you can do even if you have a spinal cord injury. You can spend time in the kitchen, you can cook, and I wrote a cookbook 10 years ago because I was sick and tired of the dietitians. We didn't share the same view, so I figured out that in order to help my fellow spinal cord injured friends and patients not to gain weight, I had to do it myself. So we have to watch our diet. If you're in a chair, you burn probably 25, 30, 35% less calories per day. And the only way to avoid gaining weight is to eat less. And you can eat less without suffering. And it's just a matter of getting used to it. Anyway, today's Spinalis is situated in Stockholm, 2-3 minutes away from the big Karolinska Hospital, and it's in the park. It's an old military installation, and we have about 35 single rooms with wooden floors and wooden walls, and it's a pretty nice, open, quite remarkable area that does not, or setting that does not remind you of an hospital, with big, very efficient bathrooms with windows and with 2 open fireplaces that's extremely well thought of during the winter, when the newly injured spinal cord patients can have their breakfast in front of the fire. So this picture shows Claes Hulting skiing, and I tell you, this is the closest that I've come to an orgasm after my spinal cord injury. It took me about 41 consecutive days to learn how to ski, and I fell and I fell and I fell, but endurance, because I was trying to ski together with my son, and it took me, as I said, almost 40 days to learn how to acquire these skills, partly because of my level of my injury. And when I turned 50, I had an opportunity. I was given as a gift from my friends to spend one day with a chopper, and I actually went heli skiing for one day. And if somebody had told me when I was lying in a striker bed without any movements in my arms whatsoever, that one day I was going to be able to do this, it would have been a utopia. But it went that way, and today I'm also able to practice some skiing with my friends, and my friends are also 60 years plus, and we only ski when the sun is out, and we only ski for a couple of hours, because then they start to complaining about that their legs hurt and their knees and their hips and everything hurts, and I'm in my sit ski. So I have a couple of pictures left, and I show you this picture of one of the cars that the Spinalis Foundation has that our patients can use when they're newly injured. And it's funny with this car, because it generated an awful lot of fuss, because everyone was screaming on Fridays and Saturdays that you had the car last Friday and I want to have this Friday or Saturday. But it's pretty fun. And what is this? It boils down to the fact that how can you kick the ass in a newly spinal cord injured patients in order to get him or her out to get back into society? It's a matter of using the whip and the carrot. And this is more of the carrot thing, that it's a matter of motivation. You can never teach your child mathematics. You can never rehabilitate another person. You can only rehabilitate yourself. You can only learn mathematics yourself. But you can provide circumstances. You can enhance and facilitate for these people to get moving, to get their ass in gear. And in order to get that ass in gear, you have to provide with the right tools. And all of a sudden, this old, beaten up Chrysler Baron turn that way. And the next thing we bought was this BMW 1200 from the UK. This is a little bit more sophisticated, so you need to be a little bit more careful before you embark on driving this masterpiece of machinery. But still, it's a matter to get back with your bikers. And it's a matter of getting back to conduct a life, a way of living that's as close as possible to the life that you were living before you had your injury. So, best way of practicing is still the arm cranking bicycle, I think, especially for a quad with limited trunk stability. And in this, you're firm, stable, and you can work it out, and you can have a go. And my friends, my last picture shows my friend Thomas, who lives independently. He's a C6 quadriplegic. He buys his own beer and his own potatoes, and he works as a journalist. And I think that that's what we have to strive for, to don't ask for any pittiness, to exercise our legal rights to be part of society. And that can be done in a lot of ways. We have to claim our rights to have the right tool, the right medical gear, the right technical aids, such as catheters, such as wheelchairs, all these things that we need in order to conduct a good way of living and survive. Thank you very much.
Claes, can you hear me?
I can hear you, yes.
Okay. Look, thank you so much for sharing all your, thank you, Claes, for sharing your expertise. There's quite a nice crowd in front of me who perhaps have some questions that they would like to shoot your way if you've still got a moment to stay with us and take those.
Definitely.
Thank you. So there's just a roaming microphone. I will let you know what the question is.
Hi, Claes. Can you hear me? Okay. Claes, thank you. That was a great presentation. Really enjoyed it.
Claes, an audience member is just thanking you for your time. She really enjoyed your presentation.
I come from Perth, from the original spinal unit that you showed the picture of, so that was lovely.
She too comes from Perth, and the Shenton Park that you know is now Fiona Stanley, but she worked there too.
Okay.
Very lucky. Claes,
it was a good place.
Yes. Can I ask you what your thoughts are for the future for bladder management? If you see something exciting on the horizon coming to help with catheterization and such?
I guess quite an open question around bladder management. Can you perhaps predict the future as to what sort of trends may be coming in the near future? And yeah, would love you to share what you can see.
You mean trends in regard of treatment, or for technical aids, or for what in particular?
In regard to bladder drainage, anything we can see coming out of research or technology to help make that easier for people?
Research, technology, just in terms of how catheterization, just I think more generally around how to empty the bladder.
I think that the technique will pretty much remain where we are today. I think that the research will emphasize on trying to figure out why 30% of the entire spinal cord injury constituency do get recurrent UTIs, whereas I would say half of my patients, representing 50% of the entire cohort, never gets never get the UTI. No matter whether they spit on the catheter or what they do, they never get the UTI anyway. So there is something on the mucosa, there is something on the biofilm in the bladder that we don't know yet. And if we can somehow learn what to do in order to avoid that type of infections to occur, so we don't have to treat them with antibiotics. More and more patients are also using antibiotics prophylactically because they hate to get the UTIs, and we all know that it's not good to use antibiotics over time, or over and over and over again. So I think that we're looking for other types of drugs, other types of ways of actually trying to avoid UTIs, but using other avenues and other ways of doing it instead of using antibiotics. That's for sure. And I believe that when the threat of having more bacteria that are resistant, that threat will enforce governments and pharmaceutical agents to look for other options.
Thank you for that response, Claes. From the audience, are there further questions? We do have someone. Just a moment, Claes.
Hi, my name's Matthew. Just wanted to ask, has you got any pointers on maintaining SPC catheters?
Claes, there's a gentleman called Matthew. He has a question around maintaining SPCs. Do you need any more information than that, Claes?
Maintaining SPCs.
In regards to
Suprapubic catheters.
Yeah. Maintaining them in just generally?
Just keeping them, because mine blocks all the time.
Just maybe some tips or tricks on how to keep them unblocked?
Could you elaborate a little bit further on that question? I'm not sure that I grasp exactly what...
I get a lot of sand and sediment and all that sort of thing in my bladder, and then the catheter blocks from all that sort of stuff coming through.
So Matthew's just curious, with his suprapubic catheter, wondering how he might be able to reduce the blockages from sediment.
Yes. Okay. When it comes to suprapubic catheters, the one thing that's been tried recently is also to use a type of catheter that's silver coated in order to reduce the UTIs for suprapubic catheters. It has not so much to do with the clogging of the catheter, which is another issue. But of course, it's always, it has been a problem, it is a problem, and you know as well as I do that all the sort of quote-unquote ordinary tips that you get from your doctor to flush here and flush there and so on and so forth, it's still clogging, and you know, you go up in diameter of the catheter and it's still there. And it also depends on if you're using a suprapubic catheter and you have had an augmentation done, so you have a bigger bladder made out of your intestines, then you definitely get more clogging, because then you're fighting the internal mucosa of your intestine that generates this mucosa, that clogging element. I'm sorry I don't have a very good answer on that question.
No, that's okay. Thank you.
Is there any other questions?
Hi, my name's Rachel. I'm just wondering, with the cookbook that you had, is there anything you recommend to eat in your diet that helps the bladder to prevent UTIs and to keep you well?
Yeah, we've got a great question, Claes, from Rachel. She's just, in reference to your cookbook, are there any particular foods or meals that could be prepared to prevent urinary tract infection? I suppose just alluding to improving gut flora or something that might facilitate reduction in UTIs?
When it comes to what you should drink or eat in order to avoid UTIs, the only thing that's really been tested with some evidence, that's cranberry. If you make your urine more acid, like with C vitamin, it can I wouldn't say prevent, but at least keep the bacteria on a lower level. Every time when they try to do big multi-center, crossover double-blind studies with various types of agents or food, it's difficult to get good evidence. But with cranberries, there are studies that have shown that if you take concentrated cranberries, your chances of getting a UTI is slightly less than if you don't. But there are also anecdotal stories about patients that tell me that they eat this and that they eat that, and if they do this and if they do that. And sometimes there are good thoughts, and the best thing is if somebody finds a good way that they believe keeps them with less infections, fine, don't argue against that, because there are so many things that we don't know yet, and there are so many herbs out there that's been used for centuries, and a lot of them have effect, no doubt. Chinese medicine, they sometimes can, I wouldn't say that they can do magic, but at least they are thought of having good effect, even if we cannot, quote unquote, prove it with our means, with our techniques, with our society, with our frame of reference. But sometimes our frame of reference might be too limited. And I think that we should have an open mind vis-a-vis these things, that sometimes these other techniques and methods, even if they're not classical medicine, can be definitely worthwhile testing and yes.
Thank you, Claes. We just wanted to thank you for your time. I know that it's really early in Sweden. I think maybe around 2:30 or 3 a.m.
It's 3:30.
We should let you get your beauty sleep and then head to your boat, yes, which I know you love being on. So thank you so much for being with us virtually.
Thank you, Claes.
Thank you very much, and have a good continuation of your Saturday. There are a lot of good seminars left. Okay.
Thank you very much.
Thank you very much, and goodbye to all of you.
For those of you here, I just wanted to say thank you for attending the workshop. My name's Esther, and I'm with my colleagues Chris and Julie at the Wellspect HealthCare stand, just back towards where the entrance area is. We, as a company, work quite closely with Spinalis, both being Swedish-based companies. I'm not sure if you know much about us, but we actually, just over 30 years ago, developed the world's first intermittent hydrophilic catheter. And today we're still really passionate about improving bladder care for those who need that point addressed. So we'd love to speak with you. Julie is actually a qualified nurse in neurogenic bladder for almost 25 years. So there's her expertise that is still with us today. And we can talk you through a new app that's available for free, which actually allows you to see both a questionnaire that's endorsed by clinical references to help prevent UTIs, as well as just some general information and tips that also might just facilitate you with where you are at and any resources that you might need. So thank you so much. Hope you have a good expo.
Thank you, Esther.
And thank you, Julie. As Esther and Julie said, they will be at the stand all day today. If you have any questions or one-to-one, go and visit them there. Thank you.